steps, promoting patient safety, improving health.
My name is Adam Hoffman of the West Virginia STEP Center at West Virginia University. This is Reversible Causes of Cardiac Arrest. It's part of a larger ACLS class, also known as the H's and T's. So I don't have any conflicts of interest with this information. Presenting the information is best known based on current medical evidence, but it's not designed to replace your institution's policies, procedures, or good medical common sense. So what are the H's and T's? This mnemonic was first described by the American Heart Association in the ACLS class, designed to aid your memory in the most common causes of cardiac arrest. Certainly not all-inclusive, and you must account for your individual patient presentation as you work through the causes of an arrest. We found this is a useful tool to help you organize your thoughts and work through in a systematic way to eliminate any reversible causes for your patient in arrest. So let's walk through these individually. The first on the list, it's the very common, maybe the most common cause of cardiac arrest, is hypoxia. Usually stems from some other underlying condition and is often present regardless of the underlying arrest cause. So the key here to treatment is high-quality airway management and high-quality CPR. And we're going to return to this a lot. One of the best things that we've seen throughout all of the studies is that high-quality CPR saves more lives. So that really comes back to, remember, you need to oxygenate your patient, good ventilation, good airway management. But if you're not returning the blood to the lungs, it's all for naught. So high-quality CPR is where this really starts and ends to fix that hypoxia. Of course, all of our arrest patients should be ventilated with 100% oxygen via vac valve mask. And an advanced airway inserted without interrupting CPR is best practice at this time. So the next stage we want to talk about is the hydrogen ion, or acidosis. Now this can be metabolic or respiratory cause. So this is acidosis from all comers. But remember, what would medulla do? Do whatever medulla would do, specifically eliminating carbon dioxide. As we know from our anatomy and physiology lessons in previous years, CO2 is the body's most common acid, and it's the acid side of that buffering equation. So the best way to remove or temporarily buffer acidosis is to remove carbon dioxide. So good high-quality CPR, returning that carbon dioxide to the lungs, and good ventilation management and airway management to remove that carbon dioxide from the bloodstream. As a side note, bicarb is not effective in the short term at correcting acidosis. We see bicarb giving a lot clinically in arrests, but bicarb, remember, we're giving it as sodium bicarb, which is actually both sides of the anion gap equation. So bicarb is not an effective treatment in the short term for acidosis. The best way to fix an acidotic patient is to remove as much CO2 from the system as you can, and then look for the underlying cause, likely a respiratory failure that's caused a hypercarbic situation. In a metabolic situation, we may give bicarb for specific reasons, but oftentimes the quick fix, or at least the quick buffer for acidosis, is removing that carbon dioxide. So hypothermia is common in a lot of patients, especially exposure patients, and it's usually an obvious finding. The patient shows up cold, and it's one of the first things you notice about them. Obviously, the treatment is very simple. We just need to warm them up, and how you do that's going to vary depending on what facility you're in. Things like central warming via like an Alceus catheter, which is a central catheter inserted into a large vessel, usually the femoral vein, can centrally warm or cool the patient with a hot or cold diode on the catheter. That works really well, but of course then you do have to place a central line and requires a higher level of skill. Also, not all facilities will have access to something like that. So hot packs to the groin and the axilla are oftentimes adequate to warm these patients up. You want to remember you're trying to warm up the large vessels and the blood flowing through those large vessels. Warm IV fluid can be used and probably should be used in most of our arrest patients anyway. gastric lavage or bladder lavage, those are also options with warm fluid to help warm these folks up. So hypo or hyperkalemia. So potassium exists, obviously we know, in a very delicate balance in the body. Most labs will tell you 3.5 to 5 millimoles per liter of potassium. The body is very sensitive to potassium because it's responsible for all muscle contraction and its balance in the electron gradient across the cell membrane. And that includes cardiac muscles. So potassium must exist in this delicate balance. Without enough potassium or with too much potassium, your heart cannot generate an electron gradient to perform its contraction. So hypo K, obviously you need to give them K back. But remember, the only time we give K boluses is in lethal injection. It has to be done very slowly. So typically 20 to 40 milliequivalents an hour is the maximum amount of potassium you could get. Too fast and you will kill the heart and not be able to revive the person. So much more common than hypokalemia is hyperkalemia, and we see this a lot, especially in renal failure patients. Often we say that renal failure patients are hyperkalemic until proven that they're not. So we use an acronym called C big K drop. This is one of my favorites for hyperkalemia. We're going to start with calcium, preferably calcium chloride. Calcium gluconate we give oftentimes on the floor to patients with hyperkalemic who are not in arrest. But remember, the calcium gluconate has to be separated from the gluconate in the liver for the calcium to become bioavailable. So calcium chloride is immediately bioavailable, and it has 3 times the elemental calcium that calcium gluconate does. So for this reason, we tend to use calcium chloride in the arrest state. The one downside with calcium chloride is that, one, it's caustic and can burn veins, which is why we don't give it typically to conscious patients. But also, it really burns during injection. If your patient's in arrest, I'm pretty sure they won't complain. So that's why we typically use calcium chloride in the arrest patient. The next letter is B for bicarb. Now, we talked earlier about not giving sodium bicarb typically for acidosis. But in this case, we do want to give bicarb for the sodium. And the sodium's going to, remember, potassium exists intracellular typically, and sodium exists in the extracellular space. So if we increase the amount of sodium, we help maintain the electron gradient across the cell membrane. So that's the purpose of giving bicarb. We're not actually giving it for the bicarbonate, we're giving it for the sodium load. So in these hyperkalemic patients, calcium and bicarb work together to prevent those arrhythmias in the heart, but they don't actually do anything to remove the K or to change the balance of K in the extracellular space. All we're doing is changing the electron gradient at this point. So insulin carries potassium, and it binds with potassium across the cell membrane, so it will drive potassium into the intracellular space. So that's why we give insulin in these hyper-K patients. So it doesn't get rid of the potassium. I want to make that clear. It's not going to get rid of the potassium in any way. It only is going to hide it for a little while. So you can drop their serum potassium with insulin, but you're not really removing the potassium from the system. So we still have to follow these things up with a more long-term treatment to actually remove the potassium from the body. So the next on the list is glucose, and glucose doesn't really do anything for the potassium, but it does prevent you from killing the patient with hypoglycemia. So this is really the only reason we give glucose is to balance the insulin administration and so the insulin moves into the intracellular space. All right, so Kxalate is a drug that binds with potassium and it allows it to pass into the GI tract and then it is excreted that way. So it can take hours to days. This is not a fast process, but this actually does remove potassium from the body. So this is one way, once we get these arrest patients back, you can choose Kxalate to help excrete that potassium and actually remove it from the body. And probably the most definitive treatment, especially for somebody in renal failure, is dialysis, which directly removes the potassium. The one downside with dialysis is they need to be pretty stable before you can send them up to a dialysis unit. So once we get these patients back and we have their blood pressure somewhat stabilized and we've stabilized the potassium at least for the time being, then we can move them to a dialysis unit or to an ICU that's capable of performing dialysis so that potassium can be removed from the body. So also note that it doesn't fit in my nifty little C big K drop algorithm, but albuterol will also shift potassium into the intracellular space. So Albuterol is one that you'll see commonly given in hyper-K. It's easy to give. It's a little harder to give in the arrest patient, but if you have somebody that's in a peri-arrest situation, you can give them multiple albuterol nebulizer treatments, which will help drive the potassium back into the cell and help maintain that level at least for a little while. K-wasting diuretics, obviously, like Lasix, will help the patient excrete potassium, but also causes volume loss. They take hours to work, and of course the patient has to have functioning kidneys for any loop diuretics. So keep in mind that Lasix, we talk a lot about watching their K level when they're on Lasix, but it's probably not an effective way to remove potassium from the body. If you have the time to wait for Lasix to work, you probably have the time and the ability to stabilize the patient for dialysis, or use KXLA, which is a more effective way that's not going to volume deplete the patient quite as much. All right, so moving on to the next H is hypovolemia. So most arrest patients you'll see will have a fluid bolus. They'll get a fluid bolus partly as a way to help administer and flush drugs into the system, but also as a way to help correct any underlying hypovolemia. So remember to think about hypovolemia from all causes. Typically we see this, or we think of this as massive bleeding in a trauma patient. But most children most children have hypovolemic states from nausea, vomiting, and adults can too. So keep in mind that hypovolemia doesn't have to be massive blood loss. Just because the patient isn't bleeding on the outside doesn't mean they're hypovolemic. So most arrest patients, unless there's some good reason not to give them a fluid bolus, it's worth giving them a liter of normal saline or some other isotonic fluid. So some other options include, especially for trauma, mass transfusion of blood. So that's that MTP protocol. We're giving lots of O-negative blood through like a level 1 infuser, confuse it warm and very quickly. You might also choose a more balanced fluid that isn't quite as acidotic as saline, like Plasma-Lite. Volume expanders have been very popular in the military. Still can find some use here. Something like Hexten might be appropriate as well. So that's all of the H's. So let's move on to the T's. The first one I want to talk about is tablets and toxins. So when we talk about tablets and toxins, we want to talk toxidromes. And we're not just going to blindly treat the toxin itself. We're going to look at the toxidrome, right? And so we want to assess the patient globally. Do they have pinpoint pupils, or do they have dilated pupils? Do they have the mad as a hatter, red as a beet, dry as a bone from a sympathomimetic overdose? So look for those toxidromes and focus your care specifically towards that antidote. Most of the time, supportive care with high-quality CPR, good fluid resuscitation, high-quality airway management, those will be all you need to fix the tablets and toxins. I'm often asked about Narcan, right? Narcan is the miracle drug that apparently came out a couple of years ago, even though we've been seeing it and using it since the 90s, that it magically reverses opiate overdoses and is the Lazarus drug, so to speak. It brings patients back to life. But does Narcan really work that way? Truthfully, no. Narcan won't have any effect on the arrest state of a patient. When you think about the toxidrome for opiate overdoses, the patients become apneic, and it causes that significant respiratory distress. And so that's why they arrest. It's actually a hypoxic, hypercarbic arrest. So the way you fix that is with high-quality CPR. Am I saying you can't give Narcan? No. You can give Narcan if you so choose, but know that it's not going to change the arrest state. Narcan is not a magic drug, and it's not going to magically restart that patient's heart. You need to still make sure that you're focused on a high-quality CPR and good airway management, because the likely cause of an opiate arrest is actually the respiratory depression. Okay, so tension pneumothorax. We're going to move into some trauma pathology now. So this is one of the easiest traumatic arrest causes to reverse, but keep in mind that it can also be a spontaneous cause. So not all tension pneumos will present from high-speed trauma, right? It is a clinical finding. You should not find this via chest x-ray. Most places now treat traumatic arrest as if they have a tension pneumo and will electively decompress both sides of their chest. This one's a really easy, low-risk procedure that you can perform in traumatic arrest who have a very, very low survival rate anyway. So needle decompression, follow your institution protocol. Typically, I think we're still doing it between the second, third intercostal space, or just above the third rib. Usually on both sides in these traumatic arrest patients. Keep in mind this can be a spontaneous finding, so don't rule it out just because your patient doesn't have a history of trauma. So pericardial tamponade, this is the next T. The easiest way to assess for this is with point-of-care ultrasound at the bedside. You can see it quickly and readily, and you can, with a little bit of practice, you can get good at doing those ultrasounds during the arrest state, during your pulse check pauses. So high index of suspicion for tamponade for anybody who is a high energy trauma. And also, as a side note, anybody with recent cardiothoracic surgery history. Again, that's pretty likely in those patients as well. And of course, the treatments of pericardial centesis. All right, so thrombosis, and this one we're going to talk about is pulmonary thrombosis, or PE. So again, this is a great thing you can find with point-of-care ultrasound, but it's always better if you knew prior to arrest. And these patients oftentimes present with PEs and are unstable, and we're suspicious of them arresting right before they do. So if you already know that these patients have that condition, we want to move as quickly as we can to get them to definitive treatment. This is a really high mortality rate once the patient's arrest. So the key here is to either restart the heart as quickly as possible and get them to interventional radiology or CT surgery where that PE can be removed, or to choose a thrombolytic for, let's say, TPA. But keep in mind, once you give a thrombolytic, you must continue to work the arrest for an additional 30 minutes. So if this is not somebody that you want to work for an additional 30 minutes, it's probably not indicated to give the TPA, right? So if we're already 25 minutes into an arrest, an asystolic arrest, it's probably not appropriate at that point to give TPA. Now we're talking total arrest time of an hour, right? So keep that in the back of your mind. If you're going to give TPA, you need to give it really early. There's not good evidence out there that I've seen yet on outcomes of TPA and PE. Most of those patients have died, but again, most of those in those studies, the TPA wasn't even started until 15 or 20 minutes into arrest, and we already know what the outcome data looks like when you're in arrest for that long. All right, so the next one is coronary thrombosis, or STEMI, right? So this is one of those in adult patients we should always consider. Is this a STEMI? Does this patient need a cath? So it is a likely cause in a lot of adult arrest, especially adults with ventricular arrhythmias. So keep that in mind. If you have somebody with persistent ventricular arrhythmias, that's oftentimes the underlying cause. So the key to treatment here is PCI. If you can get them to the cath lab as quickly as possible, these patients often have a great outcome. And many caths can be done now while a Lucas device per se is being used. So they can check with your cath lab and follow your institution-specific policies. But if you have an automatic CPR device, they may be able to do the cath through that, which means you don't have to wait and get the patient's heart restarted if you know that this is a STEMI patient. Or thrombolytics. If you're not in a PCI-capable facility, you can give thrombolytics at the bedside. But again, the same rules apply with PE. If you're going to do this, you have to do it early or it's not going to work. So keep that in mind. The faster we can get them to PCI, or the faster we can get that coronary opened up, the better the patient's outcome is going to be. So that's an overview of all of the H's and T's. If you have any questions, please feel free to email me. For our medical students, if you want to post a question in the SOUL site to that discussion board, you're welcome to as well. Happy to entertain any questions. Thank you for all you do, and be safe out there in this crazy time.